Okay, good afternoon, everyone. It is a pleasure for me to be sharing with you today this lecture that I will deliver about the pediatric cancer and retinoblastoma management in Latin America. I am Guillermo Chantada. I am the scientific director of the Hospital Pereira Rosell in Uruguay. Let me start with a little bit of history. You are probably not so familiar with the situation in Latin America in terms of the treatment of pediatric oncology patients. As you can see here, our specialty started near the 70s. Before that, as in many parts of the world, this specialty there was no treatment, there was no cure for children with cancer. And in Latin America, there was a very exciting situation those days because we were able to set up clinical research cooperative groups. And one of the first ones happened in Argentina. They had really good output at that time. They produced randomized studies that were published in the international literature. But as you see here also in the slide, you can notice that the access to treatment was really poor. There was good science, good research, but still the access for the children to be treated and the results were really poor. In the 80s, new treatment groups emerged, especially in Brazil. The SOBOPI group was very active, and the access became wider. Children could access to treatment. Some of them could be cured. And paradoxically, cooperative groups were not improving and not increasing. And those were the days in the 80s and mostly in the 90s where these cooperations became global, especially thanks to the work at the SIOP of the International Society of Pediatric Oncology, started doing international protocols, mainly from Europe, but also involving big centers in Latin America. That was an interesting time. Clinical trials could be done in Latin America, but mostly restricted to Brazil, Chile, Argentina, and Uruguay. And the access in the rest of the continent was very poor, and many children in Central America, in the countries like Peru, Colombia, Bolivia, Paraguay, was not possible. They were simply not treated. And the very few that could be treated should travel to other countries to procure treatment. Because different factors, mostly about regulations, that made it more complicated to work in international cooperative groups. The standards, especially in Europe, became more difficult to comply by the Latin American groups. So in the early days of this century, of this millennium, it was really more complicated for us in Latin America to participate in international trials. But again, the access became really booming at that time, especially in the first years of the 2000s. So now, at that time, children in Central America, for example, could be treated with some regional groups, like as you see here, the AHOPCA in Central America, the Gallup group later on in South America, that I will talk a little bit later about it, became more active. And the access is now probably including most of the continent. Most of the countries provide some access. Most of them provide access to all children, and very few of them to some children free of charge for the treatment of cancer in our region. So where are we now? We are in a moment where we have, as I said, very good access. The regional cooperative groups are increasing. There's a new one called CLEOP, which is supported by St. Jude. St. Jude Hospital was really instrumental in helping the development of pediatric cancer all over the continent, especially in Central America. And this is where we are now. We are in a very exciting time because, as I will mention later, we have also now a WHO program for children with cancer. So these are the recent advances in our specialty. I can say that now throughout the whole continent, we have pediatric oncology services, usually in public hospitals, so children have access to treatment in most countries, possible with the exception of Bolivia and some other countries that have little access in our continent, but now I can say it is something that we can deliver the treatment, perhaps not the ideal treatment, but we can deliver treatment for most of the children with cancer in our region. Interestingly, one thing that happened in large countries like Brazil, Argentina, Mexico, where in the 80s and in the 90s, there were just big centers in big cities, and that was it. Children that lived far away in smaller provinces didn't have the chance to be treated near home. So many of them were not treated. Others could travel to big cities and treated there. But in the past 20 years, there was a movement from the big centers to smaller centers in each of these countries. Many pediatric oncologists were trained, many hospitals were opened in these smaller cities, and pediatric oncology programs could be settled in those facilities. We don't know yet the results, but all we can say is that the access for children is easier and possible in many times where it was not in the past. In many countries, like Peru, for example, there have been a movement, mostly by NGOs, to have a pediatric oncology law. So in those countries, for example, in Peru, as I mentioned, the pediatric oncology treatment was not granted by the state. But now, after, I think it was 2 years ago, it is by law that the government should cover all the aspects of treatment. And there are other countries following that path, like Paraguay, for example, and in other countries like Chile or Argentina or Brazil or Mexico, despite Mexico is going backwards in some issues now with the problems that they have because of the discontinuation of the Seguro Popular, which was really covering all the children with cancer. These countries have already granting access to treatment for all children without their ability to pay, without considering their ability to pay. And that led us to a change of paradigm. We have data in many, we have national registries in some countries or regional registries in others, but now we have data, we know which our problems are. So now that is also explaining why we are not right now involving us too much in international protocols, because we found that some of these protocols were directed for the treatment of children in Europe or in the US, and their problems were not the same as in our centers, where we have specific problems like late diagnosis, abandonment of treatment, socioeconomical issues, lack of some drugs. So we are now in this, as I said, an exciting time of generating our own protocols, treatment strategies, addressing these local, regional, and sometimes global problems in children with cancer. But we have problems, as I list here. Treatment access is improving, but it is not equal. So in some countries, children can access to different levels of care, different quality of care, and that also involves the different results. There are problems with the availability of essential medicines. Sometimes drugs that are essential are not available. Sometimes they are available. They are cheap in Europe and in North America, and extremely expensive in Latin America. That is really a big problem with drugs like actinomycin D, which cost $8 in the US maybe, and they will cost $800 in Latin America. So there are also some problems in the quality of drugs, especially there has been a lot of work in Brazil with L-asparaginase, and a very bad product that had a lot of allergic problem and toxicity, and that was coming from, was a biosimilar drug. And the quality of blood products is in many instances less than optimal, and irradiated blood products are not easily available, and there are really some issues in that field. In many countries, as I said, in a few countries, I would say we have data, national data on survival, but most of the countries don't have. So we are doing the first steps in the registration of these children, but still we don't know much on the survival of children with cancer in our region. We are going to deal with that later. And also late diagnosis, that is still a problem in many countries. Has many factors, has been studied very well in many countries, especially in Brazil, where sometimes there are socioeconomical problems that in the families that they have no funding, they have no transportation, they can't take the children to the hospital on time. But sometimes, as the Brazilian group studied in retinoblastoma, for example, once they got to the health system, it really takes a lot of time. They go many times, the doctors are on strike, the hospital is closed, no possible to be seen, the children go back home, it takes forever, many months sometimes, and we'll miss an opportunity to maybe sometimes to cure a child with a curable malignancy if it is diagnosed timely. And in many countries, we still face the problem of treatment compliance and limitations in palliative care, for example, like easy access to pain medicine and high quality palliative care is not possible. Sometimes there are cultural issues which are very difficult to manage. And we, in many countries, especially the work that has been done in Central America by the AHOPCA group, was really great, trying to address this problem locally, trying to support the families and have them complete the treatment. Sometimes it's sometimes they can't afford it. Sometimes they have 6 other children that if one is treated in another town, the other ones cannot go to school, the parents cannot work, they cannot feed their brothers and sisters of the ill child. So it is really, in many countries, there's still a big problem of treatment compliance, because sometimes children could be cured and the parents abandon treatment, and when they come back, they are not curable anymore. So I talk about the survival of children with cancer in Latin America. We have some data, and you see here that these are the estimated 5-year survival in the whole world, just focused in our continent. You see the green ones are the countries in the US and Europe, Australia and Japan. And you see that Argentina, Uruguay, Chile, Costa Rica have really relatively good survival rates, averaging 70–75%, not reaching the ones that you will see in many European or in the US countries, but really getting very, very close. And other countries look like yellow, as you see here. They are around 50–60%. I would say that much of the continent, because that involves Brazil, Mexico, and Peru, and Ecuador, Venezuela, Colombia. This is the largest population of children with cancer in the region. But you see here that countries are looking near red. So you see, for example, Bolivia, many Central American countries still are getting less than 50% survival rate, 5-year survival rate, children with cancer, when it should be near 70–80% as the international standard. So there's a lot of things that we still need to do in our continent to improve survival rate in those children with cancer. And why? What happens? So this is a very interesting paper from Argentina, the country where I come from, even though I work in Uruguay. You see here in Argentina, we have a national data. We have a national registry. It covers more than 95% of all the children with cancer. You see here the data in many different tumors. Compared to Colombia, which is not a national registry, but a regional registry, and compared to Europe, to the Eurocare, in the same time period. So you see that, for example, in all tumors, we were about a 3-year survival, around 61 compared to 77. There is a gap. There is a gap of about 15% survival rate in Argentina, which is one of the countries with highest survival results compared to Europe. And why is there? In which tumors you see that issue? You see, for example, in ALL, there is the same difference between 15% approximately. You see here the major differences are in brain neoplasms. You see that the difference, that the results in our continent is very bad. In neuroblastoma, you see that we are about 50% compared to 70% in Europe. We are quite good in retinoblastoma, which I'm going to discuss later, because we are only 6 points different compared to Europe. But you see here, for example, Wynn's tumor, which is a tumor that is curable in 90% of the children in Europe. It is not even 60 in Colombia and 76 in Argentina. So this gap is really big in most tumors, and especially in the ones that require more supportive care, like leukemia and brain tumors. And the reasons that they are not the same is not because we don't do the good treatments, it's because the other factors that I mentioned before, the late diagnosis, the poor compliance, the lack of resources. In fact, sometimes we don't have enough beds for treating all the children, and all the factors that I mentioned earlier affect these survival rates. So it is not easy. It's not that we have to go to Europe, copy the treatment you guys do in Europe, go back home and do that treatment, and then the results are going to be like Europe. That is not going to happen. This is not the way. We need to improve our results. We need to find which are the problems, attack those problems, and getting close to the results in the developed world by doing that. Sorry, because this slide is in Spanish, but this is official data from the registry in Argentina, just to show you that even though you may feel disappointed with my previous numbers, you see here that even though we are not in the same place like Europe, but we are getting closer every day. These are the results in the period of 2000-2004, which improved in the next 5 years, and then later improved in the next 5 years up to 2014. The new data are coming up, and they are really getting much better. So that is something to be optimistic. We are improving every day. We are not there yet, but we are getting there, getting closer every time. The same in Brazil. You see here, this is a very good paper that was published a few years ago already, but it shows like how the trend in mortality in leukemia in Brazil is going down since the 80s to the 2000s. So you see here that it is still, in the rest of the paper, you see here that is different in the major and more developed cities compared to the rest of the country. So there is a lot of social inequality depending on where the child is treated in the same country. So this is a hallmark for many countries like Brazil, Mexico, and Argentina, mostly in our continent. Also, this is a very nice study that was published this past year about, this is a hepatoblastoma. This is a very rare tumor. So the authors in Argentina in the National Registry looked at a very good number of children. It was 138, which is very high to this very rare tumor. And they found that the results in the centers that have liver transplantation, which that means that not the children need liver transplantation, but that means that the surgeons there I used to operate on the liver of children, and they have better results in this tumor that relies so much in the quality of the resection. So that is also to think that we should improve the access of children with very complex tumors to the high complexity hospitals in our countries. So even though we think that we improve the results by opening units in smaller cities, these specific children with high-risk tumors should be treated in large referral centers for achieving better results. Some more reasons to be optimistic. As I said, the trend is better in all the countries. I think we have a new generation of pediatric oncologists which are comfortable in the global and collaborative world. They want to be collaborative. For example, we have a very active Latin American society, as is said here, like SLAOP. It's a Latin American Society of Pediatric Oncologists. Every meeting we do, 10 years ago, there were 200 people going. Now there's 2,000 people going, thanks to the virtuality, but also thanks to this attitude of the young pediatric oncologists that want to work together and generate results. Also, we have support from international organizations. I'm going to talk about that later on, especially the WHO, St. Jude Children's Hospital, as I mentioned, and others, St. Joan de Déu Hospital in Barcelona, for example. And we have a lot of parental groups that are working very hard for advocacy, sometimes even funding the treatments, funding the drugs in many countries that the government don't support the chemotherapy drugs, and they fundraise and they purchase the drugs so the children can be treated and in their country. So, and they are stronger every day. Every day is a new one in each country. So these are another reason to become optimistic in our continent. This is what I mentioned about the cooperative groups that are now operating in the continent. You see here, for example, the Central America AHOPCA. It has protocols for these tumors and have already enrolled more than 3,000 children in countries that have lots of problems, like Guatemala, Salvador, Nicaragua, Panama, Dominican Republic. So they have a very strong support from St. Jude, from Monza in Italy, and they really generate important data, treatment guidelines. They're really, as you see here, these are the list of the tumors that they have protocols. The 1P is about prospective. So they have, for example, for retinoblastoma, they are in the 3rd protocol already. And so they're really working very hard. In South America, Gallop is started only in Chile, Argentina, Uruguay, and Brazil, and now is including many other countries in the continent. The number of children is a little bit lower. It started later, but because the resources are higher, we can do at Gallop randomized studies. We have even developed a phase 2 study and a phase 1 study with a new drug developed in our labs in Argentina. And we have, especially for solid tumors, a very long list, especially including retinoblastoma, where we are now in the 3rd protocol already. There's a new cooperative group called CLEOP, also with support from St. Jude, and it involves Mexico. Mexico was relatively late to join the cooperative groups in our continent. You know, it's a very large continent, so sometimes now in the virtual world, I think it's easier, but taking a plane from Mexico to go to a meeting in Brazil will cost much more than going from Mexico to Europe or to the US. So it was extremely expensive in the past. I think the virtuality now is helpful for that. So now Mexico is also involving a lot in the treatment in the region because it has a lot of experience, big centers, many children. So they take part of this CLEOP group. They have 2 protocols. It's a newer group, but has a lot of support. And we are working together with Gallup, for example, in histiocytosis, for example. So this is happening now in our continent. This is really something that makes us very happy, very proud. Also a lot of work, need a lot of resources and commitment to make it work. And it was extremely important, the work that, sorry again, a few words are in Spanish, and this is the WHO program that started a couple of years ago worldwide, and in our continent, it started in Peru. They are really doing a great job. They are working very hard, mostly to commit the governments in the necessity for providing the treatment of 6 cancers that were selected for this program, the 6 cancers that should be cured in more than 60% of the children, because now in the developed countries, they are cured in 90% of them. So this is a very ambitious program if you put it in perspective, because it may seem that the objectives are not so bold, but if you put it in the context that just children are not even being treated in many parts of the world, that will save millions of children in the 2030, where the program is going to be evaluated. So now, as you see here, we are a little bit delayed because of the pandemics. We are around here at this time. So the program is running up and running in Peru, and it is starting right now in other countries like in Panama, in Guatemala, and it's also a little bit delayed in Haiti, for example, but we are getting there. And the work that is being also supported by the Pan American Health Organization, so it has a lot, a very strong support from these international organizations that finally recognized that cancer is a priority for their agenda. And I was told that I have to speak a little bit about retinoblastoma, which is my specialty in the field, and probably that is the tumor that you might be more interested. And you see here that we are doing very well in Latin America. This is the results of the first, these are the results of the first Gallup retinoblastoma protocol for unilateral retinoblastoma. You see that the results are extremely good, 98% of event-free survival, which is exactly the same as the results in the Europe and in the children oncology group in North America. This included Chile, Argentina, Uruguay, and one center in Barcelona. And we were able to collect a high number of children with a protocol that we designed with our research, with our pathologists, with our way of treating children. And you see the results were extremely good. We are now in the second study that was opened 3 years ago already. There are about more than 70 patients treated, again, based on our results, based on our research, addressing our problems. And I have to say that we have only one case that had an extraocular relapse after this protocol. So the results are at least similar to the one at Gallup 2, and we now in this protocol, we reduce the treatment and make it more special to a definitive, a well-defined population in retinoblastoma. So we are getting the same results with less treatment, less cost, less morbidity for the children. So let me conclude by saying that unfortunately, even though you see that I am quite optimistic, there's still a lot of inequality in the Latin American area. There is, we are working on that, but this is a characteristic of our continent. This is difficult for us as pediatric oncologists to modify that. But we are designing projects and treatments based on that and trying to address that in the way we treat the children. We have an activity of cooperative groups all over the continent, as we didn't have in the past. We have the WHO program that we didn't have in the past, that is addressing these 6 tumors, including retinoblastoma. And we have innovative retinoblastoma treatments, as I mentioned recently, achieving very good results in line with what you have in Europe and in North America. So I finish with this. I thank you very much for your attention, and I look forward for your questions. Thank you very much again.